Our second speaker today hardly needs an introduction as this morning, as I'm sure you may have seen him speak yesterday and on Friday as well. Professor Peter O'Sullivan is a specialist musculoskeletal physiotherapist who consults 3 days a week in a multidisciplinary practice and is a professor of musculoskeletal physiotherapy at Curtin University. Today, Peter's going to enlighten you on some of the new directions in managing non-specific chronic low back pain. Thanks, Peter.
Thanks very much. Well, the voice is a bit croaky from last night, but I feel better for the exercise. Before I start off this talk, I changed a little bit because a number of people have been muttering, hang on a second, this was the bloke who, whoa, that slide shouldn't be there. Yes, here we go. This was the bloke who was talking about stabilising exercises in a publication 14 years ago. And if we look at the current evidence for management of non-specific low back pain, it's not a great story if you look at the high-quality papers. We look at the systematic reviews and some of the papers that have been presented here, and Chris Maher's presentation the other day, looking at the influence of different interventions for the management of non-specific low back pain. It tends to suggest that no intervention is superior, that there's minimal change in pain or slight changes in pain, moderate changes in disability, but whether you take a stabilising approach or a behavioural approach or a graduated exercise approach, you're seeing a very, very similar response. So what shifted from 1997 when this paper was published? And I think the first thing that I'd be very clear about, that this is a very specific group of patients. The people with spondylolisthesis, I don't think, reflect what we see in this non-specific back pain area. I did publish a paper in 2000 describing different clinical presentations for non-specific low back pain, chronic low back pain. Although if I had my time again, I would change the title of this paper to look at different movement behaviours around back pain, to look at a cognitive functional approach to management, because I think the patterns that we observed in that paper and described in that paper were the patterns that we've been able to identify in the validation studies we've done subsequent to that. But some of the belief systems around those patterns have not held up in the evidence. And that really stimulated me to present this paper, Diagnosis and Classification of Back Pain Disorders, looking at maladaptive movement behaviours as a mechanism for pain in a specific group of patients. Now, how did this process come about? Well, first, I think instability was the wrong word for the non-specific group. There wasn't good evidence to support the use of that word, and the word in itself can be catastrophizing and induce fear. The clinical experience was, for non-specific low back pain patients, they presented in a very heterogeneous way. There are some patients who didn't have clear movement behaviours, who showed excessive patterns of motor activity, who appeared to be worsened with the administration of targeting individual muscles. In fact, our subsequent research has identified excessive motor activity as a very common scenario associated with many of these chronic pain disorders. We realised that we needed to have a system that acknowledged the multidimensional nature of pain, and that a unidimensional nature could no longer be justified based on contemporary evidence. And we looked at the research data, our hypotheses didn't hold up. We're looking at the EMG data, we found that the kinematics showed up. What we were seeing was actually a true phenomena. We're looking at the motor system. In fact, what we observed as a key marker for the back pain situation was what you see on the right there, this motor system that had a loss of variability. The system was activated and not switching off. It didn't have this capacity to turn on and off in a normal and healthy manner. So it really confronted our thinking in terms of how much we derive our practice from belief or from evidence, and also as researchers, how much we go in with a hypothesis and try and interpret the data around our belief system, or actually go, well, you know what, it doesn't fit. So we have to start rethinking what we're doing. So I talked about this model the other day of considering the multiple dimensions of pain. Of course, as a clinician, this is very challenging when you have a patient come in to consider that the disorder is a multidimensional disorder. And so we proposed this system that is linked in with the Quebec Task Force that considers red flags and specific low back pathologies, but then looks at a systematic clinical reasoning approach of understanding maybe some of the underlying mechanisms that relate to these non-specific or undiagnosed chronic pain disorders. We were very clear in clinical practice. There were a group of patients who were highly disabled who had non-mechanical or spontaneous pain. And a research project we've done this year has identified widespread cold hyperalgesia in this group and high levels of psych factors, sleep disturbance, and more widespread pain in that group of patients. We were also clear that there was this large group of patients who had very clear mechanical behaviours to their pain. They reported specific movements and postures that provoked them, certain movements and postures that didn't provoke them. And so we identified down this path on the right that this group of disorders in themselves had different presentations. They didn't look the same. Some of them had great mobility but hurt when they went into those movements. Others had highly guarded movement or movement impairments in the direction of pain provocation. And attempts to use the same interventions resulted in very different pain responses. And some of these were directional. We also acknowledged that there were different lifestyle factors that were associated with these disorders. Some of these cases had no psychosocial factors, and others had significantly high levels of pain, catastrophizing anxiety and depression. So we needed a sorting system that could first consider within the Quebec Task Force a triage, and then look at neurophysiological factors, pain location, maladaptive behaviours of movement, and then look in conjunction with some of the validated screening tools, identifying the high psych factors as well as some of these lifestyle behaviours. Now, as a clinician, I was very aware very quickly that this was the group of patients that I would include in a randomised controlled trial. I don't think any of you would question the fact that these non-mechanical and spontaneous pain disorders are very, very difficult to manage. And so we wanted to include a group of patients in a trial that that had presented with these mechanical behaviours to their pain. Now, just very quickly, these two broad groupings, what we call a control impairment group versus the movement impairment group, look very different. And this can be clearly picked up on kinematic analysis. You see this lady has no problems touching her toes, but it hurts. She has big issues coming back upwards, and that hurts. She has pain bending backwards, and that hurts. Her pain has a mechanical behaviour. She doesn't have a restricted range of movement of her lumbar spine, but it hurts when she stresses her spine in different positions. So there is a clear mechanical or multi-directional hypersensitivity in terms of the way this person's moving, and she has pain and disability. There's nothing clear on an MRI scan to define this as a pathological problem based on her pathoanatomical state. Whereas this young lady had an event, a very fear-inducing event, was taken to hospital, very high levels of pain, was told that she had to protect her back, stabilize her spine, and she had completely stopped bending. She was highly guarded, was constantly co-contracting the muscles around her trunk, and she would refuse to bend. She had clear impairments of movement in the direction of pain provocation. Now, this kind of presentation is very different, and you would suggest, logically, that you would have to use a different approach to managing it. The pain location was similar, it's in the back, but the movement behaviours were different. The patterns of control were different. The psychosocial factors were different. This is a different person. So in the last 10 years or 12 years, I've been involved in this process. We set up we hypothesized a system. We looked at the reliability, whether physiotherapists could use this system and demonstrated that that was possible. We've been involved in a number of lab studies that have identified some of these movement behaviours and identified that the kinematics of movement were the best predictor for change, not the EMG. We've conducted some case studies, and I will present to you some of the results of this randomised controlled trial. This was a study carried out in Bergen in Norway. A lot of people say, well, why Norway? Well, part of the reason is I wanted an arm's length from this trial. The group of researchers up there got money for this trial and invited me to participate in it. So I went up for 5 months and we did a reliability study, and I trained up the therapist and left, and I didn't go back until the trial had been completed. We wanted a broad group of patients for this, so we had a very broad inclusion criteria. Your pain is predominantly between your T12 and your buttocks, and it hurt with specific postures and movements. It had been there for more than 3 months. You had a VAS of greater than 3 and an oswestry of greater than 14%. You were in the study. The study recruitment was across a series of different areas. 169 first entered the study. Now, you might be interested in this as a breakdown of what this group of patients represented. About 9% were actually excluded because they had signs of specific pathology. Spondylolisthesis we excluded. We excluded those with radicular pain and with stenosis. 7% had signs of sacroiliac joint pain, not back pain, and the rest of them fit into this back pain group. Very small group had movement impairments. The majority fitted in this control impairment group. About a third had significant psychosocial factors that were identified both on examination and with the Orebro screening tool. There are two arms of intervention for this trial. The cognitive functional therapy, and this is the term that we use because we wanted to conceptualize this idea that there's not just a program of movement and exercise. This involves a body-mind approach. We wanted to integrate some of the cognitive principles around functional training and movement for these people, because we hypothesize if their movement behaviors are provocative, normalizing it, you would think, may be beneficial. The kinds of patient profile we saw, about half around the age of 40, mean age of 40, pain duration of 12, about 10 years, oswestry, moderate disability, moderate levels of pain for a mean of that. High levels of pain episodes is consistent with this group of patients as well. The interventions, the cognitive functional therapy approach involved two manual therapists, a physiotherapist. Cognitive behavioural principles were taught to both arms of the study before the study commenced, and I'll talk through the different components of this intervention. There were 7 treatments on whole, on average. The control group were based on highly skilled manual therapy lecturers in Bergen, Norway, 3 experienced manual therapists. They also underwent this training period with half a day with a clinical pain psychologist in terms of good behavioural principles and management. They could individualise their treatments and use their own clinical decision making. This involved education, manipulative therapy, stabilising exercise and cardiovascular training. Very similar number of treatments were used, and they could use as many treatments as they saw fit. So the cognitive approach, we used the Orebro to identify some of these and target some of the cognitive aspects of pain. We explained the vicious cycle of pain, the different components that they presented with. We identified the goals in terms of the kind of functional goals and impairments the patients had. We used a collaborative problem-solving approach to enter into a process of generating some collaboration in terms of the direction of the management approach. And we looked at utilising changes of belief by both giving accurate information about pain as well as looking at changing the behaviours themselves. This is just an example of the kind of scenario we would give someone of the multidimensional factors that were linked to their disorder that feeds this vicious cycle of pain. There was a specific movement training component which looked at normalising their faulty movement patterns, breaking down the movements down in a developmental sequence, enhancing body awareness, and targeting the provocative functional movements that they said hurt them. So this was very much linked to the patient's goals. We didn't do any isolated muscle training. This was movement training, not muscle training. Manual therapy was used in the movement impairment group. So we considered if there was an impairment of movement, then manual therapy could be used as a window of opportunity to change behaviours of movement. There was a functional component that followed on to this, which integrated the new movement skills into functional impairments of daily living. They were exposed to this in their daily life, this linked to their goals. This conditioning and strengthening was also integrated into this as required. Cardiovascular exercise was also encouraged for those who were deconditioned, and this was adapted based on their classification. So the kind of scenario we see here is this lady who, as you saw a little earlier, has this quite disruptive pattern of movement. You see she bends down, She can touch her toes. She has pain. As she comes up, she doesn't lift from her hips. She hyperextends through her back. And she goes, that hurts me. Now, it doesn't look normal. And if you try it out yourself, it doesn't feel too good either. When she bends backwards, she doesn't bend back through her hips. She just hyperextends the back, and she goes, that's painful. If you look at her strategy from sit to stand, you see that she has major issues with transferring load going from sitting to standing. She holds her breath. She's bracing through her trunk as she's driving through her legs. She's got very poor conditioning through her leg muscles as well. So she would have gone through a process of saying, look, let's tell you where you are in space. Let's show you another strategy to move. This old strategy looks like it's painful. Let's try something different. Let's give you a strategy of relaxing your trunk and driving that movement through your legs, of giving you strategies of controlling where your body is in space to start using your legs to drive power. And just very briefly, you can see there's a clear difference in terms of her strategy of movement here, where she's driving the movement up out of the legs instead of hyperextending out of the back. You'll see in a second the ease of movement when going from sitting to standing, where she can relax her spine and drive the movements through her hips and pelvis. For this young lady, the presentation was a little different because she had this highly guarded movement. She had believed that to bend was to damage herself. Highly guarded, she wouldn't flex her back. So there were very strong cognitive factors in terms of fear in relation to this. The first thing we had to do with this young lady is to stop her contracting the muscles around her trunk. Stop contracting her abdominal wall and her back muscles, to relax her postures, to learn to breathe into her belly, to learn to relax her back, and to facilitate flexion, the movement that she thought was going to damage her, to recover normal patterns of movement. Now, this process takes time, and it's not an easy process, but down the track, these are the kinds of things that we wanted this young lady to do. The very thing that she feared was the movement that she had to rehearse and practice and practice. To learn to get flexion relaxation back into the spine instead of this guarded, abnormal pattern of hyperactivity or co-contracting through the spine. So the two arms of the treatment period was a 3-month intervention phase and a 12-month follow-up period. I won't go through the statistical analysis. I'm sure you can come up with this when the paper is published. It's actually under review at the moment. Now, the first thing to show here, the green is the manual therapy group, and the point to make here is the manual therapy group did improve, and the improvements are pretty consistent with what is considered in the literature. So they did improve in terms of reduced disability that was maintained over time, but there was a significantly greater improvement in the cognitive functional approach. You can see here. Now, when we looked at this in terms of minimally important change, which is described at 15 months, described as a greater than 10-point change on the Oswestry, 63% of the CFT group achieved this versus 31% in the manual therapy group. For pain intensity, we saw a very similar pattern where there were improvements in the manual therapy group, but there were significantly greater improvements in the CFT group. And this was a minimally important change, greater than 1.5 in a VAS, was achieved in 74% of the CFT group at 15 months versus 41% in the manual therapy group. The effect sizes for changes in pain and disability and also pain episodes were large. There were also changes in terms of reduction in signs of depression and anxiety, reduced fear, both of physical activity and work, which was interesting because that wasn't an objective of our intervention. The other thing in terms of satisfaction levels, 94% reported complete satisfaction at follow-up versus 68%, and at 12 months this was maintained with an odds ratio of 5 in favour of the CFT group, so the patients liked it. Sick leave, which is another thing we weren't really targeting, showed that the CFT group were 3 times more likely to have no time off work in the preceding 12 months compared to the other group. Now, why the difference? Well, is it because this is a new approach? The therapists were enthusiastic, they were motivated, they believed in the system. There might have been a placebo response. We're dealing with Norwegians, and I don't know if Kari Bo's here, but nice people, but they like exercise. So how transferable is this? And of course, that will be important for the future. Or are we looking at a different approach of management that's very patient-centered, classification-based, targeted, multidimensional in nature, functionally integrated, goal-orientated, that is very much focused on behavioural change. Question. Patients liked it. That was good. So where does this leave us? Well, we came to a bit of a top of a hill. Unfortunately, at most mountains, there's another mountain that's bigger to climb. So we're involved in a 3-year follow-up with this group. We're involved in a replication study. We want to look at higher levels of disability, particularly the high fear group, which looked to respond particularly well with this intervention. We're looking at occupational groups. We're looking at the barriers to treatment and the mediators of change as well. We've also been involved in a study, some pilot work, looking at this very tough group of patients, some of the centrally mediated pain, integrating some of this cognitive functional approach with mindfulness meditation, and we've been involved with this with both a psychologist and Helen Slater at Curtin Uni. And the pilot data have identified has shown quite significant shifts for this very, very difficult group of patients. I want to just finish off by acknowledging a very important study, I believe, that's just come out of the Lancet in the last month. And this is a group led by Jonathan Hill at the Curtin University group. They've really taken what we know as the Orebro questionnaire and cut it down to make it simpler, identifying people's risk group based on these psychosocial factors. So identify high risk, medium risk, low risk group. They hypothesized the low risk group didn't really need a lot of treatment. They needed some reassurance and sending on the way. The medium risk group needed some therapy, and the high risk group needed a lot of concentrated therapy with what they called psychologically informed treatment. So special training of therapists to deal with these complex disorders. They conducted a randomized controlled trial, a huge study of I think up to about 800 to 900 people that put people into these different arms. And the interesting thing about the results of this study, as you can see here, the targeted treatment's in the red and the control group is in the blue. And what they did in this trial is that for the low risk group, which you see in blue here, they thought that they didn't need much treatment. So they didn't give them a lot. They saw them once, reassured them and sent them on the way. In the control group, those patients had a lot of therapy. And in fact, the results were no different. In the medium group, or the moderate medium risk group and the high risk group, they gave a lot more attention. Now, the interesting thing from this study is that often the high-risk patients weren't given a lot of attention in the control group because they were probably a bit too complex. So you give them to the young graduate and say, well, you look after that patient. I'm going to treat this nice one over here. This simple back pain problem, low risk, because that's much more enjoyable. And I think what we see here is they put a lot more resources into the high-risk group and showed a greater outcome. There were also considerable cost benefits to this as well. This is one of the first very large RCTs, which would suggest that a stratification approach based on risk holds for both improved outcomes as well as significant cost savings. And I think it's quite a unique study. So where does it leave us? Well, if you're dealing in clinical practice with chronic pain, it's very challenging. We know there are patients who are extraordinarily hard to change. We know there are patients where we can't influence their pain. Improving their life is a good objective. But we do know that there are other patients whose behaviours are highly amenable to change, who we can have a significant impact in. And so our greatest challenge is to continue on that journey of unravelling this process, and I'm sure it will last me well beyond the rest of my career. I want to just acknowledge a few people here. Shanton Fursum, who conducted this trial as part of his PhD, other collaborators in Norway, Elisa Kvalle and Sture Skoen, Anne Smith, who conducted the statistical analysis of this study, and my wonderful team of researchers who I'm extremely grateful to be part of, and who put up with my rantings and my clinical stories. Leon sometimes walks out, but thank you very much for your attention, and enjoy the rest of your conference.